My name is David Foley. I'm with Sievert and Martin Bergmann, and we're going to discuss LAA occlusion, in particular evolution, and what it applies to our practice in this area today. So Horst, I start with you just to tell us a little bit about the history of LAA occlusion, where we've come from and where we are now.
That started actually in 2001 when we did the first procedure. At that time, I expected to have closed all appendages within 1 or 2 years. That means 3 or 4 million patients with AFib. It took a little bit longer, as you know. But then we had the next device after the Plateau device, which was the initial device, was then the Watchman, then the ACP, and now the Coherex, and other devices are on the pipeline. So it's moving forward. I think we had very good study results, and we are on the right track.
And so the competition, obviously, between new companies on the block, as it were, and innovation from existing companies, all indicates that this is a growing and interesting field. But the biggest evidence, I guess, is in Watchmen. And maybe, Martin, you might talk a bit about the most recent large Watchmen study.
Sure. I think Watchman has really paved the way for this whole field, and we should credit that there has been an investment both regarding the doctors that were involved as well as the patients. We've seen the randomized trials, which were done at a time where everybody believed, I think, this procedure to really go against warfarin, because warfarin is so difficult to handle, and it was obvious that we need a new solution. Now with the new kids on the block, the NOACs, the field has shifted a little bit in that, at least to the guidelines, not necessarily to the belief of the people here on the table, NOACs are the first choice. But there are a lot of patients that cannot take full dose NOACs. And we can apply the data that we have on the Watchman to all these patients and say, okay, we can offer you, and we should offer you, another possibility if you can't take it for bleeding risk and others. But there has been a gap between these randomized trials and the recent development offering it to patients that have an absolute or relative contraindication. And evolution is closing this gap in that we have now 650 patients within the 1,000 patients that were done in this prospective registry that were deemed contraindicated for oral anticoagulation. And when we started back evolution, there were some people who said, well, if you apply this really to routine, it's a complex procedure, LAA anatomy is difficult to understand, there are peri-procedural risks like pericardial effusion, thrombus on the device, maybe peri-procedural stroke. So the balance between the risk and the benefit was actually unclear. Now, after evolution is finished and we see the critical 3 months data, which we presented here as a late-breaking trial, thanks to the effort of the whole investigators group, we see that with 1,000 patients recruited between October 2013 and May 2015, so we finished that much earlier than we planned, and actually the safety is much better. We only have 0.5% of the patients that have a procedural or peri-procedural serious adverse events that had not resolving outcome. This is in the range of PCI and actually pulmonary vein isolation. If you see the pericardial effusions that you have with that procedure, which is accepted for AFib treatment, it's the same range. So really, this is a huge step forward. We also now know that we can adapt the peri-procedural drug regimen to the individual patient. We have several options now, so this really puts LAA closure on the routine procedure of a structural heart team.
Excellent.
Yeah, it was actually a big concern when we finished the randomized trials that maybe when we spread this out to the community that the results may be worse and the whole technology may fade away for that reason. And this is now confirmed that's not the case. With proper training, people can do it in routine practice and have even better results than in randomized trials.
Yeah, I would say the effort that you have to put into LAA closure these days is really to identify the correct patient, to talk to him, maybe to his relatives, because we're treating elderly patients. Some of them are afraid of going on a CAS table. Once you've done that, even if you are a low volume center, you can safely do that with the current training standards that we have with the Watchman, as well as the proctoring, and actually the routine that we have all started to follow when we're doing these procedures.
So this brings us nicely to the question about is there an ideal patient? And it sounds like what we're agreeing is that every patient with non-valvular atrial fibrillation facing long-term anticoagulation is a candidate for an LAA occlusion procedure, because the randomized trials looked at people who are eligible for both and have found non-inferiority and gathering mortality reduction by LAA occlusion. And now we have evolution in real life in people who are not suitable for anticoagulation, showing us even a safer procedure with tailored antithrombotic regimens. So my question to you guys is, do you have a routine in terms of are your teams preparing patients in the same way, or are they tailoring it to the patient regarding, do they go on NOACs after the procedure, do they go on dual antiplatelet, single antiplatelet? Horst, what's
after
your...
the procedure? Okay, we prescribe aspirin for 6 months and clopidogrel for 3 months. We don't give any anticoagulation after the procedure. And we do this, I mean, stopping the antiplatelet therapy after 6 months is not based on trials, but is based on the observation that these devices get covered by endothelium. We know this from ASDP4 closures, so we are confident that this is also the case for the left atrial appendage closure devices. So we stop all kinds of medicine after 6 months.
So apart from people who have coronary disease or some other reason, if they have no other reason, then they're stopped. They're not even on aspirin after 6 months.
Correct.
And you have no adverse messages from that practice going on
signal,
for several years.
We don't have a trial, but we don't have any signal from clinical practice that this could be harmful for the patient.
Excellent. Martin,
I think there's a good argument now to follow that, because first, the Reno Vermani showed the data of the endothelialization of the Watchman, which actually, by the way, goes faster than the Amulet device because it has a larger disc. So actually, we have sort of a improved safety profile. With evolution, we now know that there is no statistical significant difference regarding periprocedural stroke, thrombus on the device, or other SAEs, whatever kind of post-procedural drug regimen you use. Even if you use nothing, or single antiplatelet, or as you mentioned, NOACs, there are slight differences, but it doesn't appear to be statistical significance. If you ask you what I do in my practice, I'm coming from an interventional PCI background, so I have a lot of patients that do have coronary heart disease. Also a lot of patients that had an acute coronary syndrome, where so far I was in the dilemma that I truly believe in the potential of the new antiplatelet drugs, but I couldn't use them in the patients that have AFib, because you know the bleeding risk is massively increased if you combine ticagrelor or prasugrel with the NOACs or the warfarin. So for these patients, I think, and I advocate, it's a very elegant way to have both diseases treated evidence-based as best as you can, applying a Watchman and combining it with aspirin and ticagrelor for 1 year. And even now we can have the argument that you need to go on with dual antiplatelet after the first year until 3 years, because we have the Pegasus data. So you're even after 1 year, you're not out of this discussion.
This brings us a little bit back to the question, which are what you asked initially, what are the ideal patients for this procedure? And we have all the randomized data is coming from patients who can take anticoagulation. And the only reason why this did not translate into the guidelines was the safety concern. But now with the data from evolution, that safety concern has gone, because the complication rate is less than 3%.
4.1% if you count everything, and 0.5 if you only count the ones where the patient was harmed so that he had a long-lasting...
So that's much lower than in the randomized trials, which means now actually we should rewrite the guidelines and make this procedure available for patients who can take anticoagulation.
But we will see new AFib guidelines coming out at ESC, I think. Horst, maybe you want to comment again. You were part of the writing committee for the EAPCI guidelines. So those are the ones that we have at the moment. And I think you put quite an effort into getting these guidelines to the current practice.
Yeah, it was some effort because I was convinced from this in 2001. So, but what we now have in this recommendation is actually, and that is more than fair, that the patient has to be informed about this option, and then the patient should decide. Because patients may always, that's not only true for left atrial appendage closure, it's for any procedure, they may decide for other reasons to go for this or that therapy. Even if there is a significant difference, they may decide, okay, take that risk, like climbing the Mount Everest has a mortality of 10%, and they decide to do it because they like it more than staying at the base camp.
Exactly, that brings a really good point about the discussion with patients and offering the option to take a closure now versus long-term anticoagulation for those who can. And I guess it brings up the differential between patients. And how do you feel, do we have a role in convincing people based on the evidence that we know that they can't possibly know because they have no medical background and maybe they Google it? But is it incumbent on us to say to people, actually, you'd be better off to have a closure than to take anticoagulation? What do you think?
Richard, what I do in my practice is I do not want to push the patient. So I say this is an option, and the results overall, when I take all the trials together, are quite similar. There's not a big difference. And the device procedure has some advantages and some disadvantages. That is a procedural risk, but the advantage is on the long term, you're doing better, and then the patient decide. I think this is the best way to proceed.
I really try to do this on the background of a atrial fibrillation outpatient clinic, and by that way you can really tailor the solution to the patient. I think what I see happening and what frightens me a little bit is that a lot of patients are now put on reduced dose of NOACs. Because people think we can stop bleeding that. Yes, you do stop bleeding, but you also stop the stroke protection that you get. It's like having the patient on an INR of 1.5, which doesn't help us at all. And I think to inform these patients that there are other options is an important thing that we have to do. Also have the community at EuroPCR. It's a common challenge for all interventional people. And the issue is some reimbursement in some countries in Europe. I think evolution also is a big step forward here, and we will see maybe new trials, but actually evolution will be the one that we have to live with for the near future.
For the foreseeable future, yeah. So we're coming around to what we believe as operators, and Horst has been a pioneer in it, and we've followed as loyal believers as opposed to heretics. And do we need to convince other colleagues that they should either be building programs like we've mentioned before in previous discussions, or referring to institutions like ours where we've already built up a large volume?
Well, I might add some details from the evolution study, because in the presentation that I gave on Tuesday, we also had the first data in Europe comparing different sizes of centers. And the reassuring thing was that we found, even if you just do 10 cases a year, with the current training standards, you have the same safety profile as centers that do 60 a year. Yeah. And this is a range where all the centers are working at the moment. What we have also seen is that you do see a difference in that the smaller centers had to do more device size changes, more manipulation in the LAA. Yeah. If you're experienced, you can end the procedure with the first release in 80% of the cases. And although we don't have the data, and we can reassure everybody to do, but you should aim to really grow your program. But EuroPCR 2016 for me is really the turning point where you see TAVI and CLIP have become routine. As far as I know, the numbers are also not increasing that much anymore. We have all the resources of the hybrid ORs around, so people should get interested and involved in this program.
I think the take-home message regarding the no difference between complications between experienced and non-experienced, it's not that the procedure is easy.
No.
I think it's a difficult procedure, but it shows that the training programs of the companies and the clinical specialists of the companies are really doing a good job.
Yeah.
And that has also been shown in the PREVAIL trial and now again at the end in the EWOLUTION trial.
Yeah.
So training is important and clinical specialists are important, and they help us to have these good results what we could obtain in the EWOLUTION trial.
I think it's a very good point, is that we need to acknowledge the role of the companies in education and support. And the clinical specialist being present makes a big difference. So I think we've probably got ourselves around to the closing point of the discussion in the round table, in the square table, is that we are firm believers that mechanical LAA occlusion is a good, effective and now safe procedure. We have the evidence from EWOLUTION now showing us that in all comers we achieve very high success rates with very low 0.5% serious complications, which is really important and represents, as you said, Martin, a substantial improvement from the randomized trials that Horst was involved in from the very start, which were associated with slightly higher than desirable complication rates. So we've crossed all those bridges. Post-procedural antithrombotic therapy has become more clear because we can use whatever we feel comfortable with for the patient, and it seems like that even aspirin monotherapy is not deleterious, and that after 6 months perhaps we can stop all antithrombotic therapy dedicated to the device treatment because the device is endothelialized. So I'd like to thank you guys for sharing in the discussion. I think we've had a very useful discussion about the current state of play with LAA occlusion, and hopefully we will be expanding this as we go.
Thank you.
Thank you.